Is there one that's a favorite? They both have sort of the same kind of indication. As you said, TAS was given after Rigo in that study in some patients. Is there an ideal patient where you might go one way or the other?
Well, I mean, when you look at the studies, there's obviously a time lag between the two studies. We don't have any experience with TAS 102 followed by regorafenib, although that experience may come clinically in some patients. But on trial with the RECORE study, you do have patients who went on regorafenib and seem to have done well on TAS 102. And for most patients, that tends to be my choice, is to continue the process to regorafenib and use TAS 102 actually following regorafenib.
Yeah, particular patients, low volume, high volume?
So, well, I mean, at this stage, I think volume is less relevant. But I think that you think about it, if a patient comes to you after multiple lines of therapy and their bone marrow is quite beaten up, you may want to think twice about TAS 102. But then if you have a patient, who comes to you with liver function abnormalities or had some significant issues with hand and foot syndrome,
maybe PS on the decline already.
Then you may want to exactly. Then you may want to think about TAS 102 first. But for the majority of the patients, frankly, in my clinic, we're able to go through that sequence with no significant problems.
And then, as we talked about before, I want to kind of come back to this one more time. So we might also have an ox still in our pocket at this point too. Absolutely. Is there a preference? Anybody want to jump in on? If you still had ox, is there a patient where you'd say, no, I'm going to play that before these drugs versus play these drugs and bring ox later? Anybody got a bias?
Just the neuropathy issue, right? So the neuropathy and the platelet count, just like Tony was alluding to. I tend to, if I can use it again, I'm going to probably squeeze it out before I go to one of the two others. And then I tend to use TAS first just because of the side effect profile, but you can argue with me either way.
And some people are saying like response, because neither of these drugs really, it's not something you're going to count on a response. So maybe somebody with more symptomatic metastatic disease, then you might have a bias that maybe ox would get you more likely a response versus not. Thoughts?
Perhaps. I mean, I think we've all reintroduced oxaliplatin. You definitely get some responses, but it's infrequent.
Yeah.
So I wouldn't necessarily count on getting disease shrinkage with that approach.
Yeah.
Okay. I think we have covered the subject of metastatic colorectal cancer, from diagnosis to multidisciplinary care, to the new drugs, to toxicity management. And so I really think this has just been a fabulous discussion. We've reviewed a lot of information regarding therapeutic strategies in metastatic colorectal cancer. And to close, I'd really like to get final thoughts from each of our panelists. And Tony, you get the easy one because you get to go first. Where are we with colorectal? What are important takeaways for our docs to have?
Sure.
You get one. Don't use them all up with one speech.
Well, I think it's an exciting time, a lot of options, a lot of potential, and we're talking about survival beyond 3 years now in most of our patients with metastatic colorectal cancer, so exciting time.
Johanna.
Here's where the challenge is coming. We're starting to break colon cancer down into multiple different types of diseases that are all going to need a little bit of a different treatment. And so, yeah, it's going to get confusing like breast cancer got confusing. And so bear with us as we figure it out. But I think in the end, it's all going to be better for the patients.
Very good. Richard.
I think we discussed it at the beginning, but I think, in terms of the multi-D approach and the definition of resection is different from surgery to surgery. So my last thought is that if you're uncomfortable with some surgeon's decision of not going for a potential resection, I think it is okay to get a second opinion from different surgery. I've done that because those are the patients that are potentially curable. So I would definitely recommend that if you're uncomfortable with the decision, to get a second opinion from another surgeon for potential resection of the liver.
Charlie, you get to take us home.
Sure, I have to go last.
Well, no, there's still lots here. Yeah.
No, you're absolutely right. And you want to know something? Bear in mind, the holy grail is how do we target RAS, right? It's 40 to 50% of patients. No one seems to figure it out. I actually think there's hope on the horizon. There are a number of approaches. And so stay tuned, because maybe the next time we see a KRAS mutant patient, we'll actually have a drug for them.
That's great. We can hope for that and cross our fingers. So on behalf of our fabulous panel, we really want to thank you for joining us, and we hope you found this peer exchange discussion to be both useful and informative.